All right, 44-year-old contractor brought into the ED after a fall off a one-story building. Vital signs: blood pressure 145, heart rate 120, respiratory 28, SpO2 98% on 2 liter nasal cannula, GCS 12, airways open, free of obstruction, has to decrease pressure on the right part of the left, with noted ecchymosis to the right lower anterior chest. His trachea is midline, no evidence of JVD, and the patient is not in respiratory distress. An EFAS shows a barcode sign on the right hemithorax. Which one of the following is the definitive treatment for this condition? Everybody, what do we think? B? Yeah, right. You've got, likely pneumothorax, possibly intention pneumothorax. I mean, he's not like hypotensive yet, but he is tachycardic, tachypneic. Where are we at here, like in this algorithm type base? We're talking about ABC, so this is going to be breathing, so we need to fix whatever's going on first before we move on to the next intervention or next part of our algorithm, which would be circulation. Let's try another one. 15-year-old high school cheerleader presents the ED test asthmaticus. Vital signs are blood pressure 101/65, heart rate 102, respiratory 26, SpO2 87, on 15 liters via non-rebreather, in spite of bronchodilators, anticholinergics, steroids, and MAG. Patient continues to worsen the decision to perform rapid sequence intubation. For her is made in order to secure the airway. Which induction agent is best due to its bronchodilator properties? I'm dizzy, right? Yep, ketamine. Good old ketamine, man. Great drug. And then EMS brings in a 30-year-old male to the ED after he was struck by a car while walking across the street. Tourniquet was placed by EMS to the patient's left mid-thigh due to partial lower leg amputation with arterial hemorrhage. Upon arrival, patient begins bleeding from the left leg. Current vital signs are 95 and 55, heart rate 122, respiratory 16, Kemp 98.2, SpO2 95% on room air, GCS 15. What is the priority in treating this patient?
Stop the bleeding.
Yeah, stop the bleeding, right? So, everybody agree? D. Could we just tighten the other tourniquet? Yeah, you probably could, right? I mean, like for like TC3 stuff, when we talk about combat casualty care, we usually throw another one on there. But you'd be surprised at how poorly tourniquets are placed. Even in the military, we like. I mean, I like to think they get a lot of training in it. But even medical place tourniquets not appropriately. And there can still be bleeding, so it's always important to check those interventions, especially if they already have one. Especially when you're like moving a patient, they're being transported, or especially like in military medicine, we're talking about today, TC3. Like if you're dragging somebody, like there's a pretty high chance that tourniquet's going to get dislodged if it wasn't placed correctly. I would like to think none of mine got dislodged when we were transporting them, but one of the flight medics said it may have happened once, and I was like, well, maybe you should have tied the tourniquet again and put another one on instead of starting an IV, but we won't go there. All right, here's our objectives today. So we'll talk about different levels of care, like our different role, or like the standard NATO, like role 1, role 2. Is everybody kind of familiar with those terms? Like a role 1 is an aid station. We'll cover it. Don't worry, and then we'll go all the way up to role 5. We'll talk about TC3, and then our pre-hospital care, and then our phases of care. Talk about some special situations, triage, pain control. They just changed, I think TC3 just updated guidelines this year, so they changed like some antibiotics and stuff like that. They always change it to like antibiotics we don't have. Oh, here, we got a little video. We'll watch this. This just goes over the different roles of care and how you treat a casualty. It's from TCMC, so it's like a simulated thing. I think I could have done a better job, but it's a good video. We'll watch it, all right? See how loud this is.
You are ambulance! If you're injured, you can still move! Strider, my boy! Over this way! Don't move! Come with me! Come here! Come here! Come here! Let's go! Get in there, Bill! I'm bleeding! Work quick, son. Clear out. You got a couple minutes. Let's go. Hurry up. Come over. Let's go. Right there, man. Right there, alcohol. Left, right, junctional, clear. Got a little cool here. Check on that. There. Still got my phone. Got it. Hopefully we're somewhere in 30. Clean. Clean. You ready? Got ready? Next flare in chest Steven. Struggling.
Oh, rookie mistake.
Starting to detect a half big strider. Hey, Strider, I'm gonna have to fight. Got an expanded hematoma right now. Folks tracking like crazy. Patients unconscious. Respiratory rates come up. Just movement. Struggling. I know you're busy, Doc. As soon as you know what you got, I need to get the 9 in this stuff. Transition this down here. Let's transition this down here. From an astral above the knee.
Hey, team leader, we're gonna get a 9 line. We got one urgent casualty, Sergeant Leonard. He's
Sucking air through that hole right there.
Yep.
Big blood on the
we're gonna
field.
need probably a ventilator on the bird. We need a rock kit.
Okay.
You got a wood plate, ready heat, full case, ready. Ventilator on the bird. We got missing number 2. This report got a
I got the mechanism for you.
okay, you got it. Last injury, we got a amputation of the right lower extremity.
Okay.
Tourniquet on board, control hemorrhage. He's got a penetrating right lower chest wound. He's got a seal on that. He's got a extended hematoma on the neck. And we've got a crack in place, breathing through the tube spontaneously.
Let me know I got a little team standing by. They're getting the litter together right now.
Okay?
So we're going to need a sort of special equipment one more time. We need a vent, blood products, Channel 2 litter, anything else.
Absolutely. That should do it. We need a rock kit.
You kind of make the same. All right, thank you. If you try to do that spontaneously,
Here's Pete.
respiratory rate somewhere in the 30s.
Okay?
Now, if you no longer detecting or hearing a high-pitched strider,
listen to Bernie. We gotta get him rolled.
Oh, I'm ready to go.
Ready to roll? Hey, let's guys. Ready for you. Just a second.
Good number.
Gooder's ready to go. Got some help here for you. Need some help? I need all 60 ball kills. Drop off power flags, any sensitive knives, radio, anything.
I already gave it to you.
Okay, on this side over here. You're on this side. I need that watch to come in on this side. Move. Take advantage outside. Grab his gear, pull it out. Pull it, please. Grab his gear, pull it out. Grab that. Grab this. Grab that.
We got a bird on the ground about 15 minutes, man. We're gonna put it down about 35 meters to your front.
Come on, let's get back up.
Well, I'm gonna get this one.
Come on, push this up. You got enough on the head?
Let's do it, baby.
Oh, we got enough on the head?
Help you support, bro.
Hey, go up here.
Now, after we rolled it. Now we're gonna trace this. Yeah, you just severed everything over here.
Back out, do your wrist raise, back out. Wrist raise is 32 in labor.
32 on labor. Alright, whenever we get a chance. You got a radio pulse counter?
Check for radio pulse. Give them a watch. I do. I got a radio pulse is present. Right now.
124. Yeah, turn it on, like that.
So you just said we leave it through there.
Still waiting for breathe, right? A little bit of air return. Second place, get it fit. A little bit of blood. Alright, get it fit for first. Fast blood in.
Put about 35, 50 meters to your front. That's security.
Got no wins, whenever I did that.
Negative. Patient remains unconscious, unresponsive. Color still good. Radio pulse still present. Still later in the day, so
stay right. Stay right. Put tape over that belt. What's that, about 8 minutes?
8 minutes. 360 coming to the plus that minute. One more. Patients again in the shape.
Let's get a,
I'll see you in the shape.
that over stretch.
Oh, yeah.
All right. How you go down there, right? Yeah, let's go ahead and get 20 milligrams of ketamine, push it right here to the IV, or the IO, excuse me. You dropped out or you want me to? I'll go ahead and get it. I'll get it wrapped up. Get it wrapped up, I'll get back. Yep.
You guys, count you down. All fixed gear needs to go
Yep.
a little bit.
Absolutely.
You,
Put that under.
strapped in, count for your sensitive, be ready to move off when we leave, when we come back.
All right, sounds good.
Travel.
Got 4 milligrams of ketamine, excuse me, 20 milligrams of ketamine. IO. Yeah. Bless you. We've got about 4 minutes left. Got the top up there.
You want to check his chronic pulse real quick?
Check, make sure you still got a radio. Right now. We got time to set a window. I still got a carotid pulse. Check for 15 seconds. We got 15 seconds. 4 minutes. My pulse was at 15 seconds. How much? I got about 122.
Looking for a carotid, looking for a radial.
Ray Pulse is still present, it's a little threaded, but at 124. And 124 rate. 34 labor.
34 labor. Looks like I still got bilateral.
Conscious, unresponsive, both still good. Now,
Okay. Everything works.
you hear the rotor, you hear the rotor. That visualize first. First beat on the ground directly. One quick. Check your stuff, man. Be ready to go. Okay, it's gonna come to you.
Come to us. Put that under speed again. All right, fly there.
Hey, brother.
Hey, how you doing?
Yeah.
All right, so the high instrumentation controlled with tourniquet right now. That tourniquet, EVM.
You have it?
Yeah, I got one.
I got it. Cool.
Okay. EVM. He's got a right penetrating chest wound, controlled with the chest seal. He started having some labor breathing afterwards, so we went ahead and Deed him. That was at 10:40, and we got the IO on board.
Did you do anything?
We got a little bit of air, a little speck of blood. Picked up a little bit. Here.
You got a little bit of blood, you said,
A
that's
little bit
where?
of blood and air.
Okay.
Okay. We had to cripe him because he had an expanded hematoma. After we criped him, airways started picking up a little bit as far as Strider went away. He was breathing on his own. Still a little rapid at 34, but he's maintaining. He hasn't worsened since we've done that DOT there. We got an IO on board with TXA running through right now. He's had 20 milligrams of ketamine IO. And
Totally fine on this guy.
we got a tunnel binder, and it's secured.
Alright.
There's the card right there. Okay, so we've got 2 sets of vitals that should stay about the same, stable, not down or up.
Okay. As far as meds, TXA,
TXA, ketamine.
ketamine, what fluids?
No fluids yet, he's had a radial pulse the entire time.
Alright. So this is.
That's TXA first
Number
dose, 1
1.
gram.
Well, actually, let's just put it back in.
Alright.
Get there, and, no headstand,
Go
no.
ahead, Stan, he's had a radial pulse the entire time.
Okey doke. And this is the only guy going for me.
Yes, it is.
Roger that. Alright, we'll call it right there. Okay, good job.
All right. What'd you guys think?
Again.
I can't watch that again. So, that's how a lot of you look, honestly. You know, I think that was mostly PAs in there. It's usually what the course is designed for, or medical providers, usually like Enroll 1 care. You know, we like to think we can do a lot better job, but you gotta realize, you know, you're gonna be nervous, you don't practice this a lot. You know, your sympathetic nervous system is running, you got gunfire and bleeding, a lot of stuff going on, so it's important you guys practice this stuff. Hopefully we never have to use it, especially, you know, with the wars all slowed down allegedly, unless you go to Iran. But it is something, you know, important, it's something you guys need to know and practice. And it's funny because the reason you see it that bad, which, I mean, it was actually decent, but, you know, there's a lot of critiques that I would give them that I could do a lot better. I feel bad for the guy that was wearing his GoPro. I hope he didn't turn it on and watch his footage afterwards. But you'd be surprised at how big of a learning tool that is, especially for like when you're training people and they see themselves on video. It's a lot better than me just telling them what they should improve on. So that's something to think about too. But it's going to be up to you guys to train them in this. And one of the reasons they, you know, that they might not have done as well, because they're usually in charge of the program, not practicing it, and they're just kind of talking through what you should do. So that's something to think about, like how your skills can atrophy if you're not actually performing this stuff. But, you know, with that said, combat medicine is different. So, you know, you have all of these confounding factors in there, environmental stressors, mission, and we'll kind of go through some of the important consideration for our TC3 or Tactical Combat Casualty Care, which is what the three different phases that they went through on their run. All right, so let's look at our levels of care in military medicine. It's going to be like our kind of NATO standard. Role 1 is going to be self-aid, buddy aid to the battalion aid station. And this is kind of what we look at from when we're evacing patients or we're sending them to a higher level. So it is important to know the differences between these. So your role 1 is going to be where most Army PAs start out at. So you're typically in a battalion. You got, however many medics, infantry battalion's got like 42, and then usually less for other ones. Other, smaller maneuver units or less important maneuver units, however you want to look at it. Role 2 is going to be your brigade. So like your brigade support battalion, some of you might actually go to BSB, and it's not the end of the world. A lot of people hate it. I loved it when I was there. We had a lot of fun. But the role 2 also could be division level, so your area support medical companies, forward surgical teams, and that's traditionally that was like the first level you would have blood capabilities at. So your role 2 has limited labs, so they'll have usually an iStat. So whatever sort of iStat cartridges, and like it was funny when I was the brigade PA at the role 2. I was like, I thought we had lab, we got lab techs, and we have iStats, and then I was like, all right, well, do we have cartridges? Well, no, we don't have cartridges. And I was like, so what do you guys actually do then? And these are all considerations you guys need to have when you're in your units, because you'll have a lot of the equipment, nobody will know how to use it, or it won't be sterilized. They're like, yeah, we got chest tube kits, but it's all unsterilized equipment. And you're like, okay, so how do we get this sterilized? These are things you guys need to consider, especially when you get down to the operational side of the house. It won't be as squared away as you think. Role 2 also has limited x-ray, so they have an x-ray plain film, and you can only view it on those old Panasonic Tough books with like a screen this big. So not the best. They should have ultrasound by the time you guys get there, and allegedly most units are starting to get ultrasounds. We'll hear how the rollout's going when Captain Williams comes for the ultrasound portion to help us out. Because he was part of that, and I think it's delayed, like everything in the military, right? Role 3 is going to be your core levels. So that's your combat support hospitals. I think they call them something. What do they call them now?
Field hospital.
What is it?
Field
Field hospital, yeah. So they call them field hospital now, but that was your typical cash, or that's what we used to call it. So that's going to be usually your highest level, or it's going to be your highest level of care in the combat or field environment. And they usually they're similar to what an MTF would be in the States. They have full surgical care, they have holding capabilities, lab, radiology, CT scanners. They're able to stabilize, they're able to, do damage control surgeries and then evacuate the patients to a higher level. And your role 4 is more definitive care out of theater. The common one that comes to mind is in Germany at Launchstuhl. And then role 5 would be hospitals in the US, so our BAMCs and places like that. All right, so some things you have to consider for military medicine is going to be your equipment and what you're going to take with you. So this is, a huge topic and something you guys all, have to learn. Hopefully you already know it. If not, you're going to have to learn what the equipment's going to be. And that's going to be one of your biggest hurdles. You're going to graduate, you're going to know how to, kind of practice medicine, or at least semi-practice medicine. And I don't mean it in making fun of the manner. I'm still learning medicine. I've been doing that for a long time now. So, there's still a lot of learning going on, but we don't teach you a lot in military medicine. So it's like how aid bags are supposed to be packed, what's in your medical equipment sets and what isn't. And a lot of times you don't find out until you're actually out using it somewhere and you're like, holy crap, why didn't we have this, that, the other? Because you got to think, some like bean counter makes your medical equipment set who doesn't ever practice medicine. So you'll find some of the strangest things in there that you'll question why they have that in your set versus something simple like steroids or something. You also want to have a copy of your 9-line medevac. Hopefully you're not the one calling it up, but you need to know it just in case it ends up being you. I mean, if you're treating the casualty, it probably shouldn't be you. A lot of things I would, inspect or check when I was battalion PA and a brigade PA is looking at everybody's aid bags, and you will be amazed at what you find in there and how unuseful most of it is. And a lot of it comes with experience and time, but it's important to look through that equipment. When I carried one, I made sure everything I had was open in it. A lot of times people keep it in there, and some nerds will tell you like, oh, it's gonna get dirty in there. It's like, well, it's gonna be pretty dirty out where we're at. So anything that can help expedite you treating that casualty or patient is important. So, just taking that extra time when your like sympathetic nervous system is in overdrive, you get a little shaky. It's hard to open some of those packages. Some of the packages are double packaged. So these are things, considerations you should have when you're out there in the field or deployed, and especially when you're training your medics. All right, so here's our MIST report. This is like a standard NATO thing now. We used to have to go through like line 1 through 5 to get a medevac launched, and you had to know more information that delayed medevac launching. So we started, we implemented this MIST report. So we're trying to get there in that golden hour, which allegedly is not going to be a thing anymore if we're in some massive war, but who knows. So we started with the MIST report and, just the locations they get launched at medevac. And that was just mechanism of injury. So what happened to that patient? Was it a blast injury? Was it GSW? Is it a rollover? Did they fall from something? And then it's what injuries are sustained. So it's gunshot wound to the right lower extremity. And then what sort of like symptoms, vital signs. So you're going to want to let them know, what the blood pressure is, if you got one. Is it just like, radial pulse, 90 over power, however you want to describe it. And then the rest of the vital signs, and what treatments you've done so far. So place a tourniquet on there. We started TXA. We have, IV hooked up, slowly running fluids, or TKO running fluids, splinted, whatever, and then they can launch that medevac. But it's important to know the MIST report. We use it too for like EMS here in the States now, or at least in Bexar County we do. And then here's our 9 line. I'm not going to go over that. All right, here's our 3 objectives of TC3. So treat the casualty, we want to prevent additional casualties and complete the mission. So, at the end of the day, the mission is what takes priority. So we try to do whatever medical care we can in order to complete the mission. So it starts pretty, relatively simply, but we developed these, standardized pre-hospital guidelines because we saw, a significant amount of preventable deaths initially when the war started that we could have fixed, and things as simple as like just extremity hemorrhage and placing a tourniquet wasn't being done. And back then, we were training like our combat lifesavers to start IVs, and they thought those sort of things were priority. So we looked at these preventable deaths on the battlefield, and the ones that were preventable, it was like 90% of them we could do something about, which it was still a small percentage of the actual deaths. Because a lot of the injuries we can't do anything about, especially a lot of the head injuries, things like that. But airway is another important one, so we decided to train everybody to do Crike. We started with more advanced airways like King, LTs, and things like that. Tension, pneumo and pneumothoraxes were a big deal. That's why I think all the IFAC kits now, or your first aid kits, every soldier should have the 14 gauge extra long needle in there, the 3 1/4. I think it might be 4.5 now, 4 something now. I think they're even longer now.
10 gauges now.
Yeah, or 10 gauges now. Yeah, I still haven't seen one, but allegedly they're out there. And then we want to think about hypothermia and that coagulopathy. So, initially we would push a lot of fluids, and we realized we were, causing, worsening coagulopathy and diluting them. They're blowing clots out, which is why in an environment where we don't have blood products, refill them with blood to do, kind of like a prophylactic hypotension. Because we don't want to, increase that blood pressure too much that's blowing clots out. But we organize it into 3 phases, which we saw in the video. So there's care under fire, which is phase 1. That's just minimal care, and we'll talk about it. And then we have our tactical field care, which is like our March algorithm, followed by, like a secondary survey type exam like we learned during our first lecture. And then we have our casualty evacuation phase. So let's dive in here. So this is going to be the first phase of care, and it's going to be very minimal treatment because we're in the assumption that, you know, they're under fire or we're in a hostile environment where we don't have a secure site, so we limit what we do in this portion, and it's really only some sort of hemorrhage control. So if we get them to place a tourniquet on themselves, that's gonna be the only thing we're doing in this phase of care, and then we're trying, you know, if we can move them to a safer environment, we can continue with the rest of our phases of care. And this one, you know, our goal, get a tourniquet, move them out of that hostile environment. If they can put a tourniquet on themselves, that would be ideal. But you know, it's probably harder. You know, we all practice doing tourniquet on ourselves and doing it one-handed, but it's hard to practice it when you're like shot in that arm. So you know, I can imagine it being a little bit difficult. But I've seen plenty of people do it on themselves in this environment. So it is possible. Here's our tourniquet options that we're using. The CAP tourniquet, I think, is the one everybody's issued in the Army. The other common one you see on there is like the soft T. They're both great tourniquets. The important thing to remember is practicing with these. But care under fire, we know we're just placing a high and tight tourniquet, so that we're not going for our normal, like if it's on the left lower extremity, we're not going like 2 inches above the wound or 2 inches from the joint. Usually we're just placing as high as we can, and then moving them out of that hostile environment during this phase. Has everybody practiced with a CAP before, hopefully? Good. All right. So the next phase of care is technical field care. So this is once you're in a semi-secure environment, you're not under hostile fire. This is when we perform our primary survey, and TC3 uses the March algorithm, which is a great algorithm. We've been using it a long time. And it's pretty close to your ABCs, right? Or your XABC. So first thing we're looking at is massive hemorrhage. And this is like in the hospital environment, we have blood products and we can resuscitate them quickly. That's the difference between the tactical environment or the field environment is we don't usually have blood. Or if we do, you might have 1 to 2 units on you or on a patrol, so you're limited. So we need to stop that bleeding as soon as we possibly can. So that's going to be our first consideration here. So, tourniquet, junctional tourniquet, our like combat gauze and things like that, or hemostatic agent are going to be what we use it in this portion. Next, we go into airway. So, are they breathing on their own? Are they unconscious? Do I have an airway? Do I need to open the airway? And then check for their breathing. If I have an airway, we move on to respiratory. If we don't have an airway, like our crike is going to be one of our main options in the field environment. And I say that we have a lot of other tools. So the iGel is another good one we can place in that casualty before we do a crike. If we need a definitive airway, we can crike them. Typically, we're not bagging them in the field, so we don't have the resources to do it. But it is an option if you need to bag them. Usually, you ain't gonna have oxygen out there. Then we move on to respiratory. So, do I have equal rise and fall of the chest? Do I need to do I need to do a needle chest decompression or needle thoracostomy to help fix that? Do I need to place inclusive dressing on there? Move on to circulation. What's their radial pulse? Do they have one? Do I need to start some form of fluids on there? And in the video there, we're still talking about Hextend, which means it's probably a really old video, right? Because we haven't used Hextend in a long time. And this was like a head of starch volume expander, but it turned out it didn't do what it was proposed to do, so we stopped using it. Then we go into hypothermia prevention, and we have hypothermia management kits out there we can use. We have just those space blankets. Our goal, once we stabilize them, is to prevent that hypothermia. We don't want to worsen that like lethal triad. But so here's our massive hemorrhage. So this is going to be placing a tourniquet. If it was placed high and tight out in the field, we can reassess that tourniquet. We can place one, either a second one if we don't have bleeding controlled well, or we can move that tourniquet to a more appropriate position. We can tape down our tourniquets as well to reinforce them at this stage because they're going to be moving over, sometimes long distances, sometimes in multiple different evac platforms or the CASEVAC platform. So we want to make sure we're rechecking those interventions. And then we can do any packing at this point, so placing combat gauze in those junctional areas. Yeah, have you guys used junctional tourniquets? Are they working pretty well for y'all? Yeah, I've never had great luck with junctionals. Well, I haven't had better luck with them than me doing combat gauze and applying some pressure. But those are out there, and something you can consider. They don't work too well in my opinion. But every soldier should have an iPack with combat gauze, and that's usually helpful. You know, we're performing our blood sweep on the casualty at this point, just looking for any more bleeding that we have. And then airway, so our airway control is pretty limited out in the field, so it's gonna be like your eye gel, your nasopharyngeal airways, which are also in everybody's first aid kits. And then usually most carry a Crite kit, or most medics carry a Crite kit. I don't know, some might still be carrying King LTs or other options that they might maybe comfortable with, but this is usually the standard right now that we give them. And if you're more advanced, you may carry better options, but it's gonna be pretty hard if you're trying to like use a laryngoscope or anything in the field. Moving on to respiration. So in tactical field care, usually you're not gonna have a chest tube. Some, you know, there may be more advanced medics like some of the soft medics or 18 deltas may have, they may have a chest tube or the ability to do a chest tube out there, but at a minimum, we're gonna do needle decompression if we suspect an intention pneumothorax. And then any penetrating wounds or open chest wounds, we're gonna seal those, so we place some sort of occlusive dressing on there. And you know, those are like the Halo ones are, you know, commonly used. I don't know if they come in the IFAC, do they? I thought they did, maybe not, maybe we just put them all in there. But usually the IFACs have them in there, or the ones the soldiers I've treated have them in there. So, you know, any sign of tension physiology, that's when we need to consider doing that needle. Chest decompression, so it's important that we practice this, we find the right location. I was telling some of the guys earlier, we did a study with a bunch of medics on, it was on Fort Hood, like 100 medics or something, for somebody's, you know, doctoral, their EMPA, you know, doctoral dissertation that they have to do. And we just evaluated them on whether they placed it in the correct location. It was, you'd be surprised at how many did not place them either second, intercostal, or fifth. They did a, you know, very poor job there. And we did it on cadavers with ultrasound as well, just checking the correct position. So it is important that we practice these and we train everybody appropriately if they're gonna be doing this. Or we're just gonna stick needles in wherever. Which, you know, it's a way. There's our needle we use, so I think it's longer now, right, or 10 gauge, is it 10 gauge? Still 3 1/4. I know they had like 4, was it 4 1/2, 4 1/4? They keep making longer and longer needles. First time I went, after the war started, all we had were like the short 14 gauges. I think they're 1 1/4 for IVs. And they didn't work very well, especially if anybody had any sort of musculature or were large. We had a difficult time, so I probably stuck like 4 or 5 in the patient once and nothing, you know, still wasn't able to penetrate the thoracic cavity. But now we have longer needles, so it's important we train with these and you guys learn them. We'll do it during our lab as well, and we'll also practice it on our live tissue model, which will be the GOAT. So those of you who don't agree with that, you can do it anyway. All right. Because, yeah, you don't want to practice it the first time on an actual casualty. Next, we go into circulation. So do I, you know, do I have a radial pulse? And then do I need to get any fluids? You know, if the situation permits, you know, we usually like to get some form of IV on those patients. So if we can get to 18 gauges, that's preferred. Larger bore if you're doing blood products is helpful. You can still push blood through an 18, it just doesn't go very fast. Then we want to consider that like coagulopathy at this point, so getting some TXA on those patients as well. If we have if you're carrying an IO needle, you should probably have like a pressure infuser with you, and they don't take up a lot of space, so it's something easy they can fit in a bag. And then we like to do that permissive hypotension, like I kind of mentioned earlier. So we're not pushing large volumes of crystalloids because we're worried about blowing those clots out or increasing their blood pressure. So our goal for like a MAP is usually like 60, which is, you know, in most patients 65 is an appropriate MAP. So we try to keep it 60 or that systolic 80 to 90. Head trauma, we want to increase it a little bit. Here are a couple of the IO options. So got your easy IO and your fast one. And the fast one goes in the sternum. The easy IO is the drill, and that can go in multiple locations. So, you know, you can do your tibia, it can go in the femur, it can go in the humerus as well. So like proximal and humerus are all great sites. You just have to remember there's different flow rates for each of those sites. And I want to say the humerus is the fastest, so that is preferred if you're looking at rate. But here's our TXA, so this should be something that all the medics are carrying. And it doesn't come in your medical equipment sensor. It used to not come in there, so maybe something you have to order on the side. It probably comes in there now. But it's something you need to consider if you got medics out there that they have TXA on them. But it's going to be 2 grams. I think, did they change it recently? Maybe not. We're still going with 2 grams here, but it's an antifibrinolytic. We're trying to, you know, prevent coagulopathy. If you suspect you're going to need blood, you know, if you have calcium, great. Most people aren't carrying calcium if they're not carrying blood with them. But did anybody carry blood in here? Did y'all carry calcium with it? Yeah. So that's something you guys need to think about if you have blood out there. You know, the fluid of choice is going to be blood. Obviously, it has to be stored and kept at it has to be cooled, so you can't just have it, you know, in a hot environment. So you'll have to have some sort of little cooler. Some day bags now have little coolers on the bottom that you can utilize, or you have a little mini like storage cooler you can fit in your 8 bags. But it is something to consider if you're going to need blood. But this is going to be preferred, followed by our other options, which are going to be like our plasma light is great. It's closer to like the physiological electrolyte concentration of the blood. So we, you know, would prefer that next, followed by LR. We try not to use normal saline in this environment, but at the end of the day, is it really that different from, you know, your plasma light and your LR? Maybe. But probably not, and we're not doing large volumes, so any sort of expander thing that helps expand that hydromatic volume may be helpful. And then here's our ratio, you know, if we're doing ERBCs, plasma platelets, which is still going to be something very difficult to have at a roll 1. So this may be something, I don't even know if the roll 2 is going to have PRBC, plasma, and platelets. So depending on if you have a FST attached to that roll 2, you might, or you might just have whole blood there. So here's our kind of endpoints for resuscitation, especially out in the field. Do they have a palpable radial pulse? And we talk about that a lot, but you know, in a tactical environment or, you know, operational environment, there's a lot going on. You're going to be pretty amped up too, so it can be difficult to even feel a radial pulse when they have one sometimes. Like I've had times where like, is that my pulse or is that the casualty's pulse? So, you know, something to consider. You know, mental status is a big one too. That's what, once, you know, you've treated a lot of patients and casualties, you know, mental status is a very important one. That's one, as long as the patient's, you know, still awake, alert, and oriented, that I like to utilize, and you can see that mental status decline, and you know, that can be an indicator too, if it's difficult to check their pulse, that they're probably need some fluids or blood on board. But like I said, our goal, you know, that radial pulse, so 80 to 90, TBI is over 110. Then we want to get meds on board, so some sort of pain meds. Typically, ketamine is going to be a great option for out in your tactical or field environment. You know, it also actually helps when you give them like a dissociative. You know, there's been a lot of research on it. Helps prevent some of that PTSD too that the casualty might have if you're giving them a dissociative, and they may not have as traumatic of a memory of the event. So, you know, I like ketamine. blood pressure neutral, so you may see that out there as well. Not so much like fentanyl lollipops anymore. I don't think they're out. I haven't seen one in a long time. Anybody, are those still out there? I think the abuse potential for the lollipops, wasn't great. And then our hypothermia, head injury, kind of prevention measures. So head injuries, you can elevate the head of the bed to 30 degrees, or you can put something under the casualty's kind of upper body to elevate them a little bit and try to reduce that intracranial pressure. And then we're trying to just maintain normo or everything for those head injury patients. So keeping their blood pressure, hopefully at 110 if you can, and then maintaining their SpO2. And then after you complete your march, we go into everything else. But at this point, usually we do hypothermia management. So at least the space blanket at a minimum, even if it's a hot environment, that patient, still runs a risk of becoming hypothermic and worsening that like lethal triad. There are, I think we have a picture. Yeah, here's some pictures on here. So the one on the right actually has like warming blankets in it, which are great. And then the one on the left is just your typical space blanket that you cover that casualty with. I've definitely used the one on the right for when I was like freezing in Alaska, Fort Drum. All right, pain control. So pain control is going to be up to you guys what they carry. So, we talk about these combat pill packs, and especially during our training, but they don't actually, there's nothing issued. There's no like combat pill pack issued. So if you want casualty or your soldiers to carry them, you have to make them yourself. So here are some options in there. Just some Tylenol, some sort of anti-inflammatory is appropriate. They just changed to the 2026 guideline very recently, and moxifloxacin is not what we're using anymore. I think I have on the next slide and changed it of what the current recommendation is. And then your ketamine. So things to consider are the difference in ketamine from like a pain dose to a dissociative or sedation type dose. So, usually like any of those lower dosage range, like 30 to 50 is appropriate for pain. Then when you're going more sedation, you're looking at 100 to 200 or like, 1 to 2 mg per kg. We also like to have an anti-nausea medication. So ondansetron, or also known as Zofran, you have PO pills that dissolve under the tongue, so those can be helpful for those patients as well. And then here's our antibiotics. So any combat wounds are going to be dirty, a lot of contamination, so we want to consider early antibiotic coverage. And this is what they just changed. So we went from Moxie and ertapenem to, I've never seen cefadroxil, so hopefully they went with something that is attainable or that you can order easily, but who knows. And then they went with my favorite, ceftriaxone Herceptin, man. That's what we give everybody for antibiotics, prophylaxis in the ER. We just give, a gram or two of Herceptin. So that is readily available. It is in your medical equipment sets. I think it does require, I think it comes in powder form. No, so you may have to mix it, or it used to. That was the latest change. All right, we'll get through this lecture and then take a break, okay? Unless anybody is dying and wants to go now. Y'all go with that? All right. Silence is compliance. All right. Casevac. So this is going to be preparation for medevac. So this is when we need to secure everything. We need to make sure that patient's wrapped appropriately. And kind of like you saw in the video, they wrapped them. It took a long time to do it, but you're going to get that casualty in some sort of space blanket typically. You need to make sure all those tubes lines are all secured in there. If you have fractures, you can splint them prior to evacuation. Make sure you got everything, all the interventions are taped. So I don't recommend using Covan on a tourniquet like they did in the video. Like they tried to do and failed, which is why we don't do that. But usually taping all your interventions down is great. When you're putting them in the space blanket, what I like to do, I like to put like 3-inch tape wherever there's an intervention and cut a little hole there so it kind of lights it up on that space, that green blanket or whatever. And so whoever's going to take that casualty can kind of know there's something there. But it is important that we have everything filled out at this point, their TC3 card, or at least something documenting it, like tape on their chest is appropriate as well. And then medevac. So you want to inform whoever you're handing this patient off to what sort of injuries they've sustained so they know what to look for. They should obviously, reevaluate that patient as they're flying, and, I'm sure flight medics are great at it nowadays. But we used to always have fights with them from, the ground guys versus air guys, and how they were checking interventions, and then it always came back on us. All right, so special situation burns are gonna be a big one, so, blast injuries are gonna cause a lot of burns. Those patients are gonna need fluids, so we'll talk about kind of the rule of tens that we use now. There's a lot of complicated formulas out there. I'll make you guys learn the rule of tens. Surgery will probably use Parkland or like a modified Brooke formula. It's just whatever the standard is. Typically, the Parklands are what we use in the civilian side of the house. Because it required more math than we can do in the military, we made it a little simpler. We'll talk about mass casualties when we do CPR, and then some joint operational stuff. But burns, try to stop the burning first. So if they're on fire, probably put it out. And then remember, burn patient or trauma patient. Has anybody treated white phosphorus injury? I treated one. It was like impossible to put out. Like that was like no joke when they talk about that. I mean, that patient died. So we didn't do a great job. But yeah, that stuff definitely burns and doesn't stop. All right, so big thing, protect the airway. So did they suffer any facial burns? If they did, then we need to consider that crike, especially in our tactical, TC3 environment. We might want to do a crike at that point, or some form of airway that we can secure. And then we need to think about, what the total body surface area of the burn is, and how quick we need to evacuate them. It's usually going to be pretty fast with these burns because they're going to have, significant injuries associated with it. They have high fluid, they're going to have a high fluid loss and require, significant amount of resuscitation. And yeah, you probably shouldn't put tape over those burns. That's not going to end well. All right, so here's our rule of tens. And so, we kind of simplified it. So any burn over 20%, we need to calculate a rule of tens for fluid rate. So I think it's pretty easy. Hopefully everybody else does. So we kind of base it on a typical adult weight, so 40 to 80 kilograms. And then we do 10 times whatever their total body surface areas burn per hour. That's going to be our fluid rate. So let's say they have like 50% total body surface area. What's that going to be per hour? Not like insulting anybody's intelligence, but yeah, it's 500. So for every 10 kilograms over 80, we add 100 milliliters. So if we're 90 kgs with 50%, we would do 600, okay? And then once again, if they are losing blood or in hemorrhagic shock, that's going to take priority over that burn. The shock or the sepsis from the burn is not gonna kill them as fast as obviously that hemorrhagic shock's gonna. And then if we can monitor urine output, our goal is gonna be 30 to 50 mils an hour. Hopefully you're not seeing an outpatient that long where you're monitoring it in this environment. And then mass casualties. So this is gonna be anything, any situation where you have more patients than you can treat. So sometimes you're at a roll one and you got 2 medics, and it's just you and 2 medics. So sometimes 2 casualties could be a mass cal at that point, depending on how well everybody's trained. So it's going to be situation dependent. Typically we're looking at like larger, a lot larger amount of casualties when we use this, but we use our IDME is what we call the triage category. So it's immediate, delayed, minimal, expected. Immediate is going to be obviously the one who needs treatment first. It's immediate, and then it'll be delayed, and we'll talk about the different situations that this applies to. But immediate requires something right now to avoid death or major disability. So this could be like a tension pneumothorax and needing a decompression right now, or a tooth thoracostomy. If we don't do it, they're going to die. That's going to be our immediate casualty or immediate triage category. Delayed is going to be something that requires surgical intervention, but right now, we don't see any risks to their lifelong eyesight if we delay it. So this could be, things like, if we have a well-controlled extremity hemorrhage, or something that might require surgery, but we've addressed that. That could be a delayed casualty. Minimal is like your walking wounded patients. And then expectant's gonna be somebody who is expected to die. That's like massive head trauma is a common one. Somebody that's already like pulseless, and you don't have the resources to address it, that could be another, expectant. Expectant will be like situation dictated on, what sort of medical support you have to help you. And then here's like the simple triage methodology. For triage, they usually say the most experienced person should be doing triage, but typically the most experienced person's you. So you're gonna have to this is something you guys need to practice a lot if you're doing mass, you have to practice mass casualty events. And typically, I like to get my most experienced, like NCO medic, is the one I like to have triaging. Doctrine, I don't know if they changed it, but like the FM, I think it was FM, it always said it was the dentist. And I was like, dentist of all people? But that was like doctrinally the person who was supposed to be the triage guy or gal, which was always fun to me. It was dentist. But here's what we're doing. So, just basic, is the casualty, do they have an airway? Are they breathing? If it's yes, great, move on. If it's no, then you want to try to open that airway and see if they can move air now. If not, then we will make them expectant. Next, we look at our breathing, like are they tachypnic? What's our breathing rate? If they're over 30, then they're probably, they probably have some sort of significant pathophysiology going on, so we need to immediately treat them, so they're being immediate. If they're not tachypnic or over 30, which is a lot more tachypnic, but we can move on to the circulation. Do they have a radial pulse? What's their heart rate? Are they tachycardic? If they have a weaker absent radial or they're significantly tachycardic, then they would be immediate. We need to address the cause, figure out where it is, so that would be triage as immediate. If it's no, then we can check their mental status. And then if they can respond to simple commands, then likely not immediate. And then if they don't, then they're going to be immediate, address the cause. CPR, so we, traditionally we don't do CPR while under fire, which hopefully makes sense. But we usually taught, like we can't do really CPR as a medic in the field, which briefs well, but it makes it kind of difficult if it's one of your guys. So this is going to be like a situation-dependent situation if you're going to be able to do CPR or not. And if you think that's going to actually improve or save that patient. And then joint operations, that's, there are things to think about. Obviously language is a big one. What sort of medications they are carrying with them, what their protocols are. And usually in whatever environment you're in or operational environment, you usually beforehand know who's there and hopefully you've actually met with them, assessed their medical capabilities, and what sort of treatment they can provide as well. So basically just work together with everybody, man. All right, I know it's a lot. What questions y'all got? Antibiotic one? Yeah. Yeah, so ceftriaxone, what it looks to me like, 2 3rd-gen cephalosporins on there. I don't know ceftriaxone is, I just assume it's a 3rd-gen cephalosporin. So ceftriaxone 1 gram, PO, and then ceftriaxone, Rocephin, IVIM, Rhino. All right, let's take a 10-minute break. And then we'll go into heat injury.
First gen.
Ceftriaxone's first gen. Okay, first gen.
So then it's, everyone's been calling me freaking, and I was like, I actually didn't realize that's why I saw some parents like, holy shit, this is really funny.
We're doing a 2000.
Oh, yeah. Oh, waste calories. interject. So let's say we're in the half year, it's like we'll put them on, it's good. But then when they get it, you can see it, you know, let's say they still need so like, you just put another one back in, or you just like, get rid of what you had, or you just say, just trying to get an idea, because I was in the hospital, got a reaction, I asked the doctors, and then you said, yeah, I guess, just trying to get an idea, because obviously the reason you're doing it.
Yeah, so, you know, tricky question, I guess, depends on the reaction. Oh, but you can say what it was. But, you know, not the ideal scenario.
Unless you're, that's the way like, there's some quality white discharge.
I was trying to correlate it, like, in the field environment.
Yeah, that's where it's real.
They better make sure you got it.
I don't think that's no. Like nothing that didn't work. Started and at the very end, like, and that was their path. That was the motion ceremony. And at the end, we promoted a keyboard, and we each put it back and forth. But no. Man, those are some great memories. So I was we did those as I walked away, I was like, I was like, and they do once a year for each one.
All right, let's
Terrible.
keep going here. We'll go through heat injuries. So you guys are gonna see this probably all the time, especially depending on where you're stationed at. You know, hot places like Texas, you're gonna see heat injuries a lot. You'll see them everywhere though. I mean, I treated heat injuries at Fort Drum. I was on a JRTC rotation. I had a hypothermia and a heat stroke in the same rotation. So some you commonly see are these environmental injuries. So it's important we know how to treat them. But before we do that, let's do some check on learning. All right, during a mass casualty incident, one deployed environment, patient is found pulse with a penetrating head injury. This one's pretty easy. There's bone versus brain matter, which is the following best described in patient triage categories. Yeah, this one's going to be expected. We would never make it this easy on an exam. No, I'm just. What? No, I probably shouldn't say this. Never mind. I was going to say, I put some of the exact questions on here that were on your exam and you guys don't miss. All right, let's do some GCS here. 75-year-old woman or female was found down at her apartment by neighbors with obvious head trauma when EMS arrives to assess her. She opens her eyes when her sternum's rubbed. She withdraws to pain and is moaning. What is her GCS score? What do we think?
Is it like purposeful withdrawals to pain or just just withdrawals?
Just withdraws to pain. So what do we give eye opening to pain? 2, good. What about, it gets tricky with moaning, but what do we usually consider that like incomprehensible words? What's that? 2, and then what's withdraws to pain? 4, yes, this would be an 8. D. Let's do one more. EMS brings in a 72-year-old female to the ED after an MBA. EMS sports patient's GCS was 12 at the scene, but seems to be deteriorating upon arrival to the ED. GCS repeated. Currently, her eyes do not open to painful or verbal stimuli. She's moaning, and her arms are extended away from her body. Vital signs are blood pressure 90/68. Heart rate 122, respir 16, SpO 294 in room air, temp 98. What is the next step in managing this patient? Yeah, so this is going to be, if we go back to our algorithm, this is going to be our airway, right? So A, we're going to need to, perform rapid sequence innovation on this patient. Hopefully none of the other ones make sense. I mean, EFAS might be performed at the same time, but this one, we need the airway right now. So we don't continue in our algorithm for our A, B, C, D, E's, F, G, till we secure the airway. All right, so here's our objectives. We'll talk about heat injuries, and they're kind of on a spectrum. So we got heat cramps, heat exhaustion, and then heat stroke. We'll talk a little bit about pathophys, how to prevent it, which prevention is going to be our key. But here's some of the stats. So it is a very commonly seen issue. Like I think doesn't Europe having a bunch of heat deaths because they don't have AC, which is silly, man. But anybody from northern states didn't have AC. Like I didn't have AC in Fort Lewis. I mean I was there in JBLM in 2010 to 13, but nobody had AC on a lot of the buildings there back then, which was kind of sad when it got hot outside. So it is something that we commonly see, and it affects certain populations a little bit more, which we'll go over. But typically, 700-ish deaths annually. I don't know why 2023 jumped like that. I don't think it was that much more hot, but yeah, there's a lot more deaths in 2023. Not sure what happened that year. All right, so a little bit on the pathophys. So, we have a great temperature regulation mechanism in our body. So we kind of regulate it through the hypothalamus and the brain. But, our body has a response to this. Typically, you start sweating, you start, you vasodilate to increase blood flow to those areas, and then you start dissipating heat from your sweat. And that heat dissipates through different mechanisms, so radiation, conduction, convection, evaporation. If we all remember back to our 7th grade science class, that's kind of how the body regulates that heat. And different, populations will be affected on how well they can do this, especially the really young, really old, things like that. And then certain methods don't work well depending on what temperature that body is. But here's, our typical core temp, it's supposed to be around that, 97.8. So usually 96 to 100. Commonly what you're going to see for temperatures in a lot of patients are 36, 38 Celsius. Some people run a little bit warmer, so some patients you see their temperature is usually 99.5. My daughter's always right at 100 no matter what. When she gets a fever or sick, it's 105. So some people just are a little bit different in the way their body regulates heat. But it starts to fail when it gets too low or it gets too high, and typically we say that's where the hypothermia kind of cutoff is, so that 95 or 35 Celsius, and then over 40 is when the body can't regulate it appropriately, so over 104, and that's when you start to see some of these physiologic responses from the body that we have to take care of, like heat stroke and or hypothermia. But there's, how our body responds. So we dilate the blood vessels, we start to increase more sweat production, and then we want to decrease heat production. Hopefully this fixes things in the behavioral control. Go to somewhere cool if you can. Sometimes it's not possible, but your heart rate increases to compensate for that vasodilation that your body has. So it compensates for that stroke volume. And then things we want to consider as clinicians is going to be what sort of, what caused this, and are there any factors that could be compounding it? So, a lot of times we'll see patients, especially, the elderly and things like that are on a lot of different medications, so these can interfere with that heat removal process that the body has. So, anticholinergics are a big one, diuretics, beta blocker, some of the blood pressure, most of the blood pressure medications can cause issues when we're talking about heat removal mechanism, just because of the way because of their mechanism of action, any sympathomimetics, and then, all of our different substances like alcohol, drugs, amphetamines and all that can compound this or cause this. But here are some of the risk factors that we worry about. So really young, really old, that's for everything, right? Like really young, really old, just everything's worse than that. We want to think about it like in the military setting, athletes, so we see this, very commonly where we're overexerting ourselves, we're not maintaining hydration, we're not eating appropriately and replacing those electrolytes. These can be a risk factor for alcoholics, obese patients. Climatization is real, so that can affect it as well. And then any prior history of a heat stroke can increase their risk for, a subsequent heat stroke. But here, and hopefully it makes sense when this happens. So, exertion can certainly cause this. So we want to think about that, especially with our jobs. Or any athletes, people running marathons, this can happen, especially, in hot environments. That's usually why they don't run a lot of marathons in the summer here in Texas, because, people are weak, I guess. But we also want to think about non-exertional, especially in our elderly patients. They don't have air conditioning. Really young children that aren't able to take care of themselves, we want to consider this. Or, if you forget your kid in the car, which I haven't forgotten my kid in the car, I've forgotten them at places and left them, but they at least weren't in a hot car. Alright, so here's kind of the different heat injuries we're going to talk about. So we have minor, and then major is going to be our heat stroke. So the minor is going to be just heat edema, so you're going to get usually like some sort of pooling in the lower extremities or some form of edema from the heat, especially in the elderly patients. You see this all the time, and they want you to fix it, and you're like, I can't really fix that. Then you get prickly heat, which can be, anybody have that in here? Yeah, it's uncomfortable, and you get a heat rash, not really any great treatments. There's like a lot of like bro science with it though that works. We don't really cover that here. And then you go into heat cramps and heat exhaustion, which are the ones, we see more commonly, especially in our field environments, hot environments, out when we're training. And then heat stroke is going to be the most severe form, and that's what we're most worried about here. But starting with the heat edema, so this is just mild. Usually, somewhere in the extremities, you're going to have some sort of edema, especially if they're on their feet a lot that day. And then it's from the heat, they get that vasodilation, and then it starts pooling in those dependent areas. Most commonly, I see this in the elderly. It can be worse if they have, comorbidities with it, like, CHF or other things. And those are what you need to make sure you're thinking about a DVT if they're coming in with just the unilateral pain. But usually we can rule these out based on their history and physical exam. And these resolve spontaneously. We don't need to do anything about it. We don't need to diurese them or anything. We just tell them to elevate their lower extremities try to stay out of that hot environment if you can. You can wear some sort of compression stockings. Next is going to be our heat rash or prickly heat or miliaria or rubra. That's just going to be a pruritic, like maculopapular, I can't talk, erythematous rash, typically over constricted clothed areas. You see it more with like wherever the body armor is rubbing on. People, if they're carrying a rucksack or backpack, it's usually some occluded area and it causes inflammation of those sweat ducts. You can use, I really don't think anything works for it, in my opinion. I don't know if anybody treated it or had it and anything worked. Like you see some wild stuff in the field, like, hand sanitizer, and they take like their cat card and slice it down it, and people say that works, which, it probably works as well as anything else. But calamine lotion, steroids can be helpful, especially if they have a lot, significant pruritus with it. You can give them some steroid creams. I've never done the salicylic acids or any of those, so I'm not, that's like in the textbook. I don't think they work, but maybe they do. But the goal is to wear, clean, light, loose-fitting clothing. Like I said, avoid getting sweaty. Yep, that would be ideal. And then other things to think about when you're seeing this, is there any sort of infection? And that's what I worry about in the ER. With any rash, like, is it infected? If not, then I'm like, okay, whatever, I don't really care. Try this cream. If that cream don't work, we'll try another one and another one. But the big thing is making sure they don't have any sort of infection, because that's something we need to take care of that can worsen. And here's what it looks like. So just those smaller, like maculopapular, erythematous lesions, usually over wherever that area was that was constricted or had clothing on there. Moving into heat cramps, so this is going to be painful, cramping, usually in the lower extremities, but can go anywhere. Typically starts in the calves, and then thighs, maybe shoulders. I feel like I see abdomen before shoulder, but I don't know. I'm not an expert in it. That's just my practice. But usually, anybody sweating profusely and they're not replacing those losses, or it's like a hyponatremia, so they're drinking this. I think actually probably more commonly I see it. People, like especially in soldiers, if they're not eating or having any meals or replacing electrolytes, they're still drinking tons of water. So there's probably some sort of dilutional hypotonic component to it. But we don't do a lot for it. It's like we're really self-limited. We want to move, take them from the environment if we can. And then usually just, PO fluid treatment with electrolytes. Typically it doesn't cause rhabdo, but it's always something to consider, especially in larger areas, larger muscle groups. So probably a deficiency in those electrolytes, so sodium, potassium, mag. And then our treatment for it, like I said, usually oral rehydration is going to be the treatment. So some sort of electrolyte solution, like the drip drop works well. PO is going to usually be the best for it. And anybody severe, we can look at doing some sort of IV rehydration. And yet, this is technically what we're supposed to do. Usually in the field, when they bring them to you by that time, you're like, let's just start some IVs and get this taken care of. But PO rehydration is actually shown to be more beneficial, and it's usually can cause less symptoms. Anybody ever done like a dehydration lab? It's not really a thing we do anymore, but I did a long time ago. And we had to drink, it was like a certain amount of fluids every hour, all day. And we did, one person was on just straight water, one was on Gatorade, one was on half Gatorade, and then one was getting IV fluids. And really what it did is we monitored our urine output. We had to drink a certain amount per hour. I don't remember what it was, but it was a lot. And like I had the water and I felt horrible having to drink that much water. The Gatorade one had lots of GI issues and some diarrhea. That was drinking full Gatorade. Half Gatorade was actually like the best off. They felt great. They're like, I don't feel anything wrong with me. And then the normal saline was really like, they didn't feel great either. So it was just an interesting lab that we did and monitored urine output. But yeah, the person who felt the best was actually the one with that like half Gatorade. All right. So moving into like heat stress. So this is gonna be basically, you know, similar spectrum. They just start to become more symptomatic, but they're not at the point of heat stroke yet. So heat stroke's gonna be that temperature over 40 or 104, and some sort of like normal mental status at this point. But they might have other symptoms, so headache, nausea, vomiting, malaise, muscle cramping, they'll be tachycardic. If you do orthostatic vital signs, they'll usually have orthostatic hypotension. We do want to consider rhabdo at this point when we see them. So this is one, you know, we like, you know, we'll try to get labs if we can. Our goal is to make sure it's not heat stroke, so we need the core temperature, make sure it's under 104. And as long as they don't have any central nervous system findings, you know, we would call it a heat, you know, heat stress or heat exhaustion or some other terms out there. But our treatment for these are, you know, volume replacement. So we want to get them some electrolytes, remove them from the hot environment. If they can tolerate PO, that's what we'll use for mild cases of these. So just some oral electrolyte solutions. We may need to do IV fluids. We don't usually need to keep them in the hospital if we can improve that patient. So, you know, we got symptomatic improvement, their temperature, you know, isn't elevating and we've controlled it. We can typically send these patients home. We just want to make sure they don't have any sort of, you know, heat stroke or rhabdo or any other conditions that could be associated with this. And then other considerations, like if you can't get them to a cool environment, you may want to keep them and monitor, but typically we can discharge these patients. And here's kind of our signs and symptoms in the spectrum. So heat cramps, you know, that's significant muscle cramping. Temperature should be normal. They're still sweating. Heat exhaustion is going to have, you know, cramps plus some other symptoms like nausea, vomiting, malaise, feeling a lot worse, dizziness, usually from dehydration or static hypertension. But their temperature isn't over 104, so maybe mildly elevated, like at 100, 101, but we're not hitting that 104 temp. And heat stroke's going to be, you know, same symptoms as the heat exhaustion and the cramps, but they have that temperature over 104, and they have some sort of neurological impairment, like, you know, they might be acting inappropriately different, you know, they might be confused. So those are patients we're going to call it a heat stroke and need to treat them aggressively. They may still be sweating, they may not. It's not, you know, not every patient stops sweating at that point, so it's not something you can hang your hat on. The heat stroke's a life-threatening emergency, so pretty high mortality, definitely fatal if we don't do anything about it. That's why we need to get a core temperature in all these patients. So anybody over 104, their altered mental status. You know, they may or may not be sweating at this point, but we want to worry about the brain. So we want to rapidly cool these patients down. And this is something you guys will, you know, certainly see, especially like training exercises and out in the field. You know, from the ER side, we need to get labs on all these patients. So we need to think about other compounding factors, comorbidities. So look at our CMP, you know, our basic lab, CBC, CMP. We need to get a CK on these patients, you know, a UA, EKG, chest x-ray. If we're not 100% sure, or if we suspect some sort of other cause, like maybe it was a meningitis that caused these sort of symptoms, we may need to do a head CT and an LP. So treatment pre-hospital, we need to remove them from the hot environment, which makes sense, right? Like let's cool them down, take them from that hot environment. You know, if we're unsure of what the cause is, you know, we can get a D-stick on them, check the glucose, especially if they have comorbidities or elderly, things like that. We want to check a glucose on them. Then we want to immediately start cooling. So remove the clothing, and then in the field we have, you know, in the military we have like our ice sheets and things like that. So we, you know, if we don't, we can spray them with water and try to, you know, dissipate some of that heat. If we have cool water and airflow, that can be helpful. You know, we can place sheets over the body, wet towels, ice if we have it, ice packs or something that can be helpful. And we can start fluids, you know, especially like on the EMS, I think start fluids pre-hospitally for those patients that we suspect heat stroke. You know, sometimes they may be able to get a core temperature depending on what your training protocols are. Like around here, most places, you know, especially in trade out, they'll usually, even like some of the drill sergeants will have thermometers and they can get a core temperature on people. But for the ED, we want to, immediately start evaporative cooling, and then IV, we need to resuscitate them, so IV fluids. We need to address whatever that cause may be. If it was just, young, healthy person, they were in a hot environment, that may be enough. But if they're elderly or if they're, young, we need to think about other causes and rule those out. But even in the ER, like, we don't have too many fancier methods usually. Like our evaporative cooling is going to be what we utilize most often in the emergency department. So some sort of, fan on that patient, and some sort of spray to help cool them down and cause some of that evaporative cooling. There's immersion cooling, which it actually works. I want to say there's a latest study that actually placing them in the cold works a little bit better, but then they can start shivering and cause almost like a rebound of those heat stroke symptoms. But there was, I want to say there was just a study that came out, immersing them was the most effective. But we're going by evaporative cooling on this. And then you do, if you don't have if you don't have an evaporative cooling method, or while you're setting the fans up, you can get ice packs on those more core areas like your neck, axilla, and groin to help cool them down. And we usually use it as an adjunct to our evaporative cooling methods. And then here's other ones we don't use very often, like bypass, okay. That might be something like in severe cases and they're on the ICU, they can use. Cooling blankets are a little bit, limited cooling efficacy in the ER, and they dissipate that cooling effect pretty quickly, so they go back to the body temperature. And the other options aren't, don't have a lot of efficacy or evidence behind them. They may work, but they may not. Like if you can do cold water, gastric, lavage, or urinary, rectal, that sounds brutal. Rectal lavage, I've never seen that. But somebody's probably done it, that might be some third world stuff going on. All right, disposition. So minor heat syndromes, we can, usually discharge them with outpatient follow-up unless we have comorbidities or elderly, we can't discharge them to a cool environment. But most of those are gonna go home, and then all the heat strokes are gonna be admitted, if they had significant, like, central nervous system symptoms, where they may be intubated. But anybody who's intubated or unstable or is gonna require like ICU level monitoring. All right, I know it's fast. Questions you guys have? Nothing? You guys are what, got like thalassemia on the brains, that's all you're worried about? Like, is that what they're talking about in hematology?
Oncology right now.
Oh, it's oncology, yeah. That's actually, there's a lot of like buzzword type stuff in oncology, I don't know, might be easy. All right, I'll hang around if anybody has any questions.